In the US, CMS recently released a new payment model called the Transforming Episode Accountability Model, or TEAM. I want to spend a few minutes going over what it is and why it matters. And even though there's no IT-specific requirements in this new model, it's very likely to create work for IT teams in the organizations that are required to participate. So this isn't a deep dive into the payment policy. It's just about understanding how decisions made at the government level tend to filter their way down to IT work. So while this particular payment model is specific to CMS and the US, the pattern isn't unique. Any initiative that focuses on tracking patient outcomes and costs over time creates similar pressures regardless of the health system. So let's start with where TEAM comes from. In the US, CMS updates payment rules on a regular cycle, including an annual set of rules that outline how hospitals are paid under Medicare. Over time, we've seen that those updates are moving in a fairly consistent direction, away from looking at individual services in isolation and toward holding organizations accountable for outcomes and costs across a broader span of care. So that shift shows up in a couple different ways. Sometimes it's quality programs, sometimes it's reporting requirements, and sometimes it's payment models like TEAM. With this new model, hospitals continue to bill Medicare fee-for-service the same way that they did before. Nothing changes there. What is going to change is how CMS evaluates the care after the fact. Instead of focusing on a single surgery or encounter, CMS is going to look at the entire episode of care around certain procedures. So the accountability is going to shift. It's not just about what happens in a specific department or area, it's about how a whole episode performed. From CMS's perspective, they're trying to address fragmentation. Major surgical care almost always involves multiple teams in multiple different settings. When all the pieces don't line up, the patients are more likely to have poor outcomes and the costs increase. TEAM is CMS saying someone needs to be accountable for how all those pieces line up. This same concept shows up in many different healthcare organizations around the world, even if the funding mechanisms look different. So let's look at some of the details. TEAM is a 5-year payment model that runs from January 1st, 2026 through December 31st, 2030. CMS selected specific geographic regions across the US to participate in the model, and hospitals that are located in those regions are required to take part if they meet CMS's eligibility criteria. Participation isn't voluntary and hospitals can't opt out. The regions are called Core-Based Statistical Areas, or CBSAs, and in total there are more than 700 acute care hospitals that are participating in the model. CMS will evaluate performance annually, not at the end of the 5-year cycle, and each performance year stands on its own with episodes that were started and completed within that performance year timeframe. I mentioned earlier that those hospitals can't opt out of participating in this model. They also can't opt out of any particular year within the model. Once they're included, they must participate in all 5, unless, of course, CMS changes the rules along the way. TEAM applies to 5 inpatient surgical episode categories that CMS defined for the model: coronary artery bypass graft surgery, or CABG, lower extremity joint replacement, such as hip and knee replacements, surgical treatment of hip and femur fractures, spinal fusion procedures, and major bowel procedures. These categories are defined by CMS using diagnosis-related group logic, and hospitals don't get to choose which procedures they participate with. If the hospital performs one of these surgeries, then they are included in the payment model. If they don't perform any procedures in a particular category, then there's nothing to evaluate for that one. Each care episode is anchored around the surgical admission for the procedure and includes pre-op activities for that visit, the inpatient stay itself, and any related care that occurs for a 30-day period post-op, even if that care happens outside the hospital. So by now you're probably wondering, what is CMS going to look at? Evaluation is retrospective, so for each performance year, CMS is going to evaluate things like which patients had a qualified episode, what services were delivered across settings and providers, how much each episode costs in total, and how these totals compare with the target price that was set by CMS. The difference between the actual cost and the target price that was set by CMS is what's going to get reconciled. That reconciliation will be adjusted based on quality performance, which means that the final result is not going to be driven by cost alone. After CMS applies their reconciliation methodology, the hospital is going to end up in one of 2 positions. They're either eligible for a reconciliation payment, or they owe money back to CMS. So now that you understand the basic logic behind TEAM, the next thing that matters is the level of financial risk that hospitals are taking on with TEAM. CMS uses participation tracks to set different levels of financial risk and reward. Hospitals don't get to pick which track they want. Placement depends on eligibility rules that CMS set for the model and the performance year. At a high level, there are 3 tracks. Track 1 is upside only, meaning the hospital can potentially earn a payment but would not owe money back. Track 2 includes upside and downside risk, meaning the hospital can earn or owe within defined limits. Track 3 includes upside and downside risk with a higher level of exposure, and again within CMS-defined limits. from an operational perspective, the track might affect how leadership reacts. Upside only tends to drive interest in monitoring. Downside risk tends to drive urgency, scrutiny, and faster escalation when results look off. So what does all of that mean for IT teams and informatics groups? Well, one good thing is that team doesn't introduce new reporting tools or any specific IT requirements that must be implemented. CMS is just going to look at regular Medicare claims reporting data to evaluate the episode spending. With that said, it doesn't mean that there's no work. Once leadership, finance, and quality teams start to review episode data, they're going to look to IT teams to answer questions that are fundamentally data and workflow related. This could lead to analysts and informaticists being pulled into things like identifying which patients fall into team episodes internally, validating episode counts against expected volumes, explaining differences between internal reporting and what CMS ultimately reconciles through Medicare claims, supporting quality and clinical teams as they look for drivers of cost and outcomes across the 30-day episode window, tracing where key events occur across the episode from pre-op care through inpatient stay and post-discharge follow-up, and responding to reporting and analytics requests tied to these episode categories. Because these episodes don't sit neatly into one single application or workflow area, this is going to require collaboration between multiple different IT teams. Like I mentioned, team is US specific, but the pattern itself isn't. Any model that ties outcomes and costs to an episode of care is going to have the same sorts of downstream needs: visibility, measurement, coordination, and explanation. And if the organization isn't hitting the targets that it wants, they may also look to IT for system or workflow optimizations or to introduce new tools that are going to help them manage that care episode better. Moral of the story, if you work in health IT, you don't necessarily need to become a payment model expert, but you will benefit from understanding the context enough to anticipate what's going to happen and what may be asked of your team and why. As always, I hope you found this helpful, and don't forget to subscribe and turn your notifications on so you know the next time I put out a video. Have a great day.